Hi, everyone. Welcome to today's state chess/grand rounds. I'm really pleased to have the opportunity to introduce one of my most successful and wonderful mentees, Dr. Wonnie Rue. So we all know Wonnie. He is a wonderful MICU attending, wonderful ILD attending, but he's also a total rock star in the laboratory. And he's developing new ways to approach fibrosing and inflammatory lung conditions, including sarcoidosis, which we'll hear about today. For those of you who aren't familiar with Wonnie, I'll just give you a brief background of him. So he grew up in Colorado snowboarding, right? And so when I think of snowboarders, I think of those people sitting on their butts at Mount Southington because they've fallen and they can't get up. And when Wonnie first came to talk about being in my lab and mentioned that he was a snowboarder, I thought, well, he's used to getting knocked down a lot on the mountain. And he also is used to getting back up and continuing. And so he's probably the right temperament for working in the lab, particularly my lab, where we're known as like the queen of negative data on the TAC fourth floor. After that illustrious but ill-fated career that did not end in the Olympics, Wonnie did undergrad at Emory Medical School at New York Medical College. After a brief foray into PM&R at Penn, you did your residency at upstate in Syracuse. And then he came here for fellowship and faculty. Okay, great, got that. Wonnie really in the 13 years that he's been here has made some remarkable accomplishments. And you know, his work in the lab has really changed the way that we think about the immune system in these diseases. His work has been published in how many, like 48 papers? He has more papers than many assistant professors, and you are an assistant professor, many associate professors. These are in such esteemed journals as AJR, as our own Blue Journal, ERJ. Many of these are actually, for more junior people, Wonnie does a lot of mentorship of medical students and residents. And so when you hear 48 publications, you might think those are all as first author. A ton of those are as last authors with this whole mentoring pipeline that he has going on in the lab. So for people who are maybe more junior trainees that are looking to maybe experiment with pulmonary translational research, Wonnie's really somebody to come talk to about that. Wonnie's impact on the field cannot be overstated and is reflected by his receipt of numerous awards, such as a Parker B. Francis Award, an NIH Mentored Career Development Award, AKA the KO8, and most recently the ASCI Junior Physician Scientist Award. This was just last year. So as we now think about the future of science at Yale and in our section, and as we think about the future of innate immunity and sarcoidosis, let's sit back and listen to Wonnie and have a great afternoon. Thank you.
All right. Thank you so much for that kind introduction, Erica. Just some housekeeping stuff. If you guys want to get CME credit for attending this, this is the code. All right. So my talk today is going to be a comprehensive view of sarcoidosis. And so we'll start with just an overview and an introduction to sarcoidosis, including the clinical heterogeneity that's inherent in this disease. What the treatment landscape looks like now, work in the biomarker space, and then some of the stuff that we've been doing in the lab in really fibrotic interstitial lung disease, but of course, stage 4 sarcoidosis. So a brief overview of the history of sarcoidosis. And so this was first described in 1869 that was called Mortimer's malady. And basically, he described a condition with raised skin lesions that looked different from tuberculosis and lupus. And so the name sarcoidosis came because the granulomatous histology was that that closely resembled that of a sarcoma. Then in 1889, there was the first description of lupus pernio. I would say the investigators' names they're kind of hard to pronounce, so leave that alone. In 1899, there was another description of the word sarcoid with a patient with multiple sarcoid lesions of the skin. And then in 1900 was the first description of what's called Herforth syndrome, where you have cutaneous lesions, uveitis, inflammation of the parotid and salivary glands, and then paresthesias of the cranial nerves. And then in 1946 is the first description of what is now known as Lofgren syndrome, when you have fever, lymphadenopathy, arthritis, and erythema nodosum. And then in 1941 is what is now described as the Cavime test, where it's Cavime-Sitzbach test, where they found that the intradermal injection of sarcoid tissue resulted in granuloma formation in patients with sarcoidosis, but not in healthy control patients. So what is sarcoidosis, right? It's a multi-system chronic granulomatous disease of unknown etiology. And while the incidence of sarcoidosis is largely unknown in the United States, the estimated incidence is anywhere from 15 to 40 cases per 100,000 individuals. Sarcoidosis predominantly affects the lungs, and again is characterized by the presence of non-caseating granulomas at the site of disease, mostly in the lungs, but we do see it in other organs. And so the proposed model of sarcoidosis proposes that there's some kind of unknown antigen that elicits the activation of antigen-presenting cells, right? And these APCs, antigen-presenting cells, that present that antigen to T cells that then activates a local immune response, really mediated by resident macrophages, the macrophages that are there in that organ. This then leads to recruitment of circulating immune cells, right? So in our blood, we have macrophages and other immune cells. And so then this leads to the accumulation of both resident and recruited immune cells to form the granuloma, that like cluster of cells all together to form the non-caseating granuloma that has this histologic appearance. And so when we think about pulmonary sarcoidosis, it's really described in what's called a skating stage. He was a British physician that did a lot of work in sarcoidosis, and this scale came up in the 1970s. So the main modality at the time of chest imaging was chest X-ray. And so it kind of underestimates a presence of disease, but again, stage 0 is there's no chest abnormality, so it's usually someone with just skin findings, for example. Stage 1 is just the presence of hilar lymphadenopathy. Stage 2 is you get the lymphadenopathy plus some kind of lung disease. Stage 3 is just the lung disease, no lymphadenopathy, and then stage 4 is the presence of fibrosis with volume loss. So again, now that we have CAT scans, I think the rate of the diagnosis of stage 4 disease is a little bit higher than what we anticipate. And so, yeah, with CAT scan, so what does pulmonary sarcoidosis look like? So the classic finding is that of what we call reticular nodular findings, usually in the lobar fissures and in a peribronchovascular, like more in the center, right? With peripheral is subpleural, center is what we call peribronchovascular. You guys will see that in a lot of your CAT scan reads. And then sometimes they coalesce together to form these like mass-like lesions. And then you'll have hilar lymphadenopathy and classification. But you could also get pulmonary sarcoidosis can also look like, interstitial lung disease. So you have, the presence of ground glass opacities, you have maybe some fibrocystic changes, and then you have some fibrosis where you have traction bronchiectasis, eventually subpleural reticulation and honeycombing. cardiac sarcoidosis is something that all of us that sees patients in clinic is something that we're always concerned about because the majority of deaths are frequently have cardiac involvement. And so we see this in about 5 to 10% of patients with sarcoidosis, and about 20% of patients have cardiac involvement. The main takeaway message from this diagram of this clinical diagram is that the LGE on CMR, so that means late gadolinium enhanced cardiac MRI, that is actually the best test to determine the presence and extent of cardiac involvement. It's tricky because, again, gadolinium enhanced cardiac MR is not widely available, but it is more sensitive and for the diagnosis the diagnosis and extent of cardiac disease. You can use PET scans to monitor the disease and also to monitor treatment response. Neurologic sarcoidosis happens in also about 4 to 10% of patients. And then the biggest one that we see a lot is small fiber neuropathy. And these patients experience like these painful nerve hyper anesthesia and have dysautonomia. And in this finding, you can have in this MR, you could see the presence of cerebellar lesions. And this condition, unfortunately, is very difficult to treat. It frequently involves pretty significant and heavy immunosuppression. Dermatologic sarcoidosis. And so erythema, this is an example of erythema nodosum. It's the most common cutaneous lesion. It's characterized by painful red bumps like these little nodules that typically appear on the shins, but can also occur in other sites. And then this diagram just shows various skin lesions that are present. They're present and different appearing lesions throughout the organs. Ocular sarcoidosis, and about like anywhere from 20 to 50% of patients, and we do see this more commonly in women, particularly those of African American descent. Uveitis is probably the most common manifestation of ocular sarcoidosis. And this is something that, again, we routinely encourage our patients with sarcoidosis to see an ophthalmologist to look for any involvement. Okay. And so clinical outcomes. So the mortality rate is pretty low overall. It's anywhere from, I don't know about 1, but probably like 5 to 10%. So they do better than like traditional patients with ILD regarding mortality. And the most common causes of mortality in sarcoidosis is lung involvement, with respiratory failure and cardiac arrest being the most common. And then the presence of fibrosis in any type of ILD will also worsen, is also something that will worsen mortality. And so again, this is something that we always look for in our patients with sarcoidosis for fibrotic involvement. Now that we have some, the study was done before anti-fibrotic therapy was approved for progressive pulmonary fibrosis. So maybe we'll see a little bit better outcomes on that end. And so knowing, and so because of, so what can we do for our patients with sarcoidosis? And so here I just want to talk a little bit about what our current treatment options look like and some of the emerging therapies that we have on the horizon. And so prednisone, as we all know, is the first line therapy, and the dose can be anywhere from 20 to 40 milligrams daily, and the duration of treatment widely varies, but it is a long time. 6 months is pretty early, generally 12 to 24 months if you were to just use prednisone. And so one of the studies that recently came out in this space is called the Sarcoidosis trial. And what they looked at was high dose versus low dose prednisone that was tapered over 6 months. And their outcome was looking at treatment failure that they defined as a 25% increase of sarcoidosis symptoms, such as like cough or dyspnea. And this was measured through what we call patient-related outcome measures. So you have a 25% increase in symptoms plus worsening lung function. And what they used was a change in, I think that, yeah, this was relative change in FVC. And this forced vital capacity outcome is the primary endpoint in sarcoidosis trials, as well as a lot of those in interstitial lung disease. So you either get a worsening lung function by FVC or chest radiograph abnormalities that were attributed to sarcoidosis. So in this trial, what they found was that there's really no difference between 20 milligrams or 40 milligrams of prednisone. And this was looked at, it was unchanged at 6 or 18 months. HQOL, that's health-related quality of life, all these different outcome measures, patient-related outcome measures, there's no change. And the incidence of adverse events were also similar, which is kind of interesting. You would think that maybe the 40 milligram people would have higher rates of infection, osteopenia, hypertension, hyperglycemia, but overall, the high dose prednisone group was considered to be not superior to the lower dose patients. But one interesting observation of this trial was that in about 45% of the patients, there was disease relapse anywhere from 12 to 18 months after steroids were tapered off. So again, this study shows that you can get away with lower dose prednisone at 20 milligrams daily, but also the need for pretty extended therapy for these patients. So knowing that, half of our patients with sarcoidosis are going to need immunosuppression for an extended period of time, really is incumbent that we offer our patients steroid-sparing agents. And so methotrexate is generally considered second-line therapy. The dosing is 15 milligrams weekly plus folate supplementation. When I was looking at this, there's a fair amount of case reports where people were given 15 milligrams daily, and then they had to get leucovorin rescue, which is kind of in the political limelight now. But anyways, it's 15 milligrams, at least 15 milligrams. It's a weekly dose of methotrexate. And again, patients are going to be on this for at least a year. And so one study that also came out pretty recently was looking at prednisone versus methotrexate for first-line therapy. And so here they looked at, again, the change in FVC. They also had different quality of life measures. And so in this, the protocol that they used was prednisone was started pretty high, 40 milligrams a day. That was tapered every 4 weeks until they were on 10 milligrams of prednisone a day. In the methotrexate group, they started at a dose of 15 milligrams per week, and that was increased to a dose up to about 25 per week. This does seem a little bit high. We usually use about 10 to 15 milligrams per week, but the patients with RA, they're usually on 20 to 25 weekly. So it's not the sticker shock of how high the methotrexate dose isn't that bad. Anyway, so what they found was that methotrexate was non-inferior to prednisone. And so, in this figure, what they found was that prednisone led to this rapid increase in predicted FVC within 4 weeks. And this finding has been observed in a lot of our clinical trials or in a lot of studies with sarcoidosis and ILD, that first month of starting prednisone, if you're going to respond, you respond quite well. But then with the methotrexate group, you get this gradual improvement in FVC. And after about 24 weeks, the FVC is actually pretty much the same across groups. So you can really use this to give you some clinical rationale to maybe you could consider using methotrexate as first-line therapy. I mean, my takeaway from this figure, this has actually informed my clinical practice a lot. When I start treating patients for sarcoidosis, my protocol is I usually start them on prednisone. It's just easier for patients to remember. 30 milligrams a day for 10 days, then 20 for 10 days, then 10 milligrams for 10 days, then off. So that's the 30 days of prednisone, which should give you hopefully that nice surge in lung function improvement. So, you go 30, 20, 10 across 30 days. And at the same time, I will then start them on methotrexate, usually 10 milligrams 10 milligrams weekly for the first week, and then bump that up to 15, assuming they can tolerate that. And then we'll usually have them on that 15 milligrams weekly, rough for anywhere from 9 to 12 months. And then once we see their lung function kind of plateau, hopefully it had improved and then plateaued, and then I'll try to bring them down to maybe like a 10 milligram weekly dose. I usually give our patients at least a shot to completely come off the methotrexate completely, but a lot of times we kind of end up back on a higher dose of methotrexate. And so, most patients do seem to respond. It is kind of jarring when, a patient comes into you in clinic, they're on 0 medications and now they're on 4. But again, it's better than being on prednisone for months and months with no end. Some of the other medications that we use, Leufonamide. I don't really use this a lot. Cleveland Clinic has had a lot of success with that, but there's no loading dose. You start them on 20 milligrams daily. And again, the studies were all meant to help reduce the burden of corticosteroid use. Imuran, we use that from time to time. The max dose is 50 milligrams daily. You can just scale that up. They come in 50 milligram tablets. Imuran is the one that you have to check the TPMT enzyme to make sure that they can metabolize it. And then Celsab, mycophenolate, is the other one that we reach for a lot. Anywhere from 2 to 3 grams a day is the starting dose. For patients with sarcoidosis, if they have joint pain, Leufonamide or azathioprine are your 2 best bets. Both of those 2 medications, Leufonamide and Imuran, they have an indication in RA and used extensively in RA. So if your patient has joint pain, then those 2 are definitely should be your third line agents, assuming they've already been on methotrexate. Celsab doesn't really do anything for joints or anything like that, but it is pretty good for just someone with purely lung disease. TNF alpha inhibitors, generally considered last line therapy. There's no rigorous studies, as most of the work in this space has been mostly observational. Infliximab is the one that's been the most commonly studied and has the most potential. The rest generally probably don't work. Etanercept has failed a lot of observational studies, and a lot of these TNF alpha inhibitors generally have been proven to be pretty ineffective. So one area of emerging research has been JAK-STAT inhibition, and so what JAK-STAT inhibitors generally target is the activation of macrophages. There's right. Remember in that granuloma, you have macrophages there, and then in that whole process of recruiting macrophages to the site of the injury, interferon gamma seems to be involved. And so there are 4 JAK-STAT inhibitors that are FDA approved, and most of the studies have been off-label. One that I do want to highlight is tofacitinib, and work here has been done by Bill Damsky's group here. This was a case report that he had reported on a patient with pretty steroid refractory cutaneous sarcoidosis. And you can see that there's a significant improvement once they put this patient on tofa. And then this kind of led into their study, where they open label study where they recruited 10 patients. And again, here what they found was pretty dramatic improvement in their cutaneous lesions, and then also looking at markers of also like cardiac disease looked like it got a little bit better, and lung function, I don't think it really did. Actually, I know it didn't because I calculated the FVCs for all these people. But at least on the PET scan, it looked like the lesions were getting better. And so Bill and his group are still working in this space, and hopefully, at the very least, we could see tofacitinib be used to treat sarcoidosis. The next one that was a real darling in the sarcoidosis space up until pretty recently is efzofitimod. And so this is this is like this is a histolytic tRNA synthase that binds to NRP2, and these synthetases are important enzymes that ensure accurate translation of these receptor proteins. It ensures accurate ligand recognition. And what they found was that in some of these pulmonary granulomas are enriched for NRP2. And so using this drug, they found that in preclinical models, it inhibited recruitment of immune cells and reduced production of various inflammatory cytokines like interferon gamma, IL-6, and MCP1. And so this really brought in a lot of excitement, and they did a phase 2 study looking at the safety and efficacy of this drug. And what they found was that at the 5 milligram per kg concentration, that it seemed to improve your FVC and it did seem to kind of reduce your dependence on prednisone. And so this was, again, look, the numbers were pretty small. And so this then led to their phase 3 trial where they recruited 268 patients with sarcoidosis that were treated for a course of 48 weeks. I don't think they've published this paper. This is all based off of their press release, but unfortunately it did not meet their primary endpoint in corticosteroid reduction. Basically, right, it was no different than placebo, unfortunately. And then change in FVC was also unchanged between placebo and treatment group. The King Sarcoidosis Questionnaire is a PRO that looks at 5 different aspects of 5 different PROs, like general health, how you're breathing, medication burden, skin, and eyes. And there was maybe a slight improvement with this drug. And then when they looked at people who did endorse improvement on that King's questionnaire, they did look, if you just look at the people who responded based on their responses to this questionnaire, maybe this drug does help. And so I think hopefully they're still at least looking at this drug as a potential treatment for sarcoidosis. So, overall, to sum up so far, sarcoidosis is a rare heterogeneous granulomatous disorder that's a multi-system disease, potential for poor clinical outcomes, right? You get progressive pulmonary fibrosis, you get multi-organ involvement. The treatment landscape right now, we're looking at reducing prednisone dependence, maintaining, if not improving, your forced vital capacity. And the reason why the FVC is so important is, at least in the IPF and ILD world, this has actually been proven in sarcoidosis too. A greater than 10% reduction in your FVC over 1 year is associated with mortality. So, by the transitive property, if you can maintain that FVC, then that should potentially attenuate your mortality risk. And so, there's still, but what this all shows is we still need to be able to find out which of these patients are at high risk and who's going to respond to treatment and who's going to respond to what. There's a lot of treatment options available. Granted, none of them are directly approved for sarcoidosis, but this is where the biomarkers will really come into play. And so a biomarker is basically, is a easily measured molecule that's clinically relevant, that's valid and easily accessible, right? And it should give you an objective, quantifiable characteristic of some kind of biologic process. And so the biomarkers that are currently used in the sarcoidosis space, so you have ACE, right? And ACE has been found to be elevated in granulomatous pulmonary diseases, particularly expressed by epithelial cells. But unfortunately, with ACE, it's pretty nonspecific that it can be elevated in a host of different conditions. And so, diagnosis based off of ACE levels aren't really great. We do sometimes use it for, we will get it on baseline and then see if, and maybe use it as a marker for treatment responsiveness. And you can order ACE and you can order soluble IL-2. And it's expressed by, in its IL-2 receptor, it's expressed by activated T cells. Remember, that's part of the granuloma formation. And then it's that alpha chain is released as a soluble IL-2 receptor, and you can measure that in the circulation. And it's used to assess a disease severity in a host of different conditions. And it's maybe, IL-2 also suffers from the same problem as ACE. It is a little bit more specific, but it can be elevated in autoimmune disease and different malignancies. But maybe it does look like, again, has some treatment responsiveness. This study out of Japan in about 70 patients showed that, the soluble IL-2 levels do go down to that of someone with quiescent disease. So maybe we can use that as a marker of treatment responsiveness. The next one is chitotriosidase. This, we found that it's it's a chitinase that's involved in really what we call chitin-containing pathogens, different like fungus and stuff like that. And so it has immunomodulatory effects that again involve macrophage recruitment and stimulation of different pro-inflammatory, pro-fibrotic cytokines. And what they found was that this enzyme activity is higher in sarcoidosis patients relative to healthy controls. And the levels do go up with more extrapulmonary disease. And it seems to correlate quite nicely with ACE levels. And so, again, maybe this could also be something else that we can also measure to kind of track how patients respond to immunosuppressive therapy. And the studies that I've highlighted so far in sarcoidosis, unfortunately, one of the limitations of a rare disease like sarcoidosis is kind of the relative circumspect nature of the work that's done. It's mostly single center studies. And so the NIH has made an effort to at least study sarcoidosis. The first effort came with what we call ACCESS. They enrolled about 700 patients with different forms of sarcoidosis, and this went on from 1995 to 2003. And then the most recent example of this kind of multi-center effort is known as GRADS, where they enrolled about 368 patients from 2013 to 2015. And so we have actually Yale was actually one of the GRAD sites. And so in our lab, we actually have plasma samples from both patients from the ACCESS cohort and GRADS cohort. And so having access to these multi-center studies across different generations of patients with sarcoidosis, this kind of empowered our own biomarker work. And so the first thing that we looked at was what was called a plasma collagen neoepitope. So, just tissue remodeling involves abnormal extracellular matrix production. And this ECM supports organ structure and different cell processes. And it's like a dynamic composition of proteins and glycoproteins, with collagen being the most common. And so you have the ECM is constantly in a state of turnover. And so in the circulation, you're going to have these collagen degradation fragments or neoepitopes, and you can measure them, and they've shown to have diagnostic and prognostic value in different inflammatory fibrotic diseases. And at the time, whether or not what the relevance of these neoepitopes in sarcoidosis was largely unknown. And so what we did was we used these ELISAs that measure protein levels, and we were able to measure both collagen degradation and collagen formation. And what we found was that In both cohorts of sarcoidosis patients, there was elevated levels of collagen degradation. When we stratify patients by scanning stage, again, 0-1 means no lung disease, stage 2-3 means inflammatory lung disease, and stage 4 means fibrotic lung disease. We didn't really find any difference in collagen degradation or formation in the circulation. When we looked at people with a disease outside the lung, so pulm means just, disease in the lung only. Extrapulmonary disease we classified as having up to 4 organs involved, and multi-organ sarcoidosis we defined as having 5 or more sites of sarcoidosis. And we found that in both cohorts that there is elevated collagen formation. And it makes sense that, a systemic multi-organ disease would have more involvement of these would have excessive collagen formation and turnover. The next molecule we looked at was IL-15. And based on this title of this paper, you can pretty much guess, we actually didn't find anything there was no significant changes across in sarcoidosis. But it was still a good study that we wanted to perform. And so IL-15 is really involved in the elaboration of in non-caseating granulomas. There's going to be this like Th1 cytokine response, and so and a lot of these Th1 cytokines have been associated with inflammation, and so IL-15 has been involved in a lot of the signaling. And so again, we didn't know what the role of IL-15 in sarcoidosis was. One of the limitations in sarcoidosis is that there's no accepted animal model to do this type of preclinical research. Looking at, we just can't model it we can, just nothing's been accepted. And so what we did was we used this enzyme called TDM, which is a cord factor from mycobacterium from TB, and used that to model sarcoidosis. And we found that, when you give mice TDM, it does induce we call it granuloma-like formation. And so we give these mice this injection of TDM, and they do form granulomas in their lungs. And then, so to really study the biology, the basics of biology, right, is you either knock it in or knock it out. And so we had various transgenic mice. IL-15 transgenic mice overexpress IL-15, knockout mice will, and then we also were able to either knock out IL-15 or knock out the IL-15 receptor. And, as much as we looked, and we looked pretty hard, there was no difference across mice. But the fact that we're able to get these mice induce granuloma formation in the lung, I think was actually the most important value added to the study. Again, we went to our grads cohort, and again, what we did find that in the BALs of these patients, they did highly express IL-15, but there's actually no clinical relevance when we looked across scanning stage or looked at multi-organ versus pulmonary-only disease. And so, biomarkers remain an active area of investigation. It looks like we can detect the presence of extrapulmonary disease, and looks like there's some evidence that the biomarkers in existence now can at least track treatment responsiveness. But really, in the studies that exist now and the work we've done in the lab, we've not really been able to find an association with pulmonary fibrosis related to sarcoidosis. So fibrotic sarcoidosis, this is again stage 4 disease, right? About 5% of all patients present with pulmonary fibrosis, and about 15 to 20% of all patients go on to develop pulmonary fibrosis. And a lot of the morbidity and mortality of sarcoidosis is related to fibrosis. The main symptoms being an unrelenting cough, just debilitating dyspnea, and really severe fatigue. And their mortality rate is super high. And they're really not, at this point, once you have fibrosis, they don't really they barely respond to immunosuppressive therapy. And the current available anti-fibrotic agents, when I wrote this at the time, it was only Ofev and Esbriet. Maybe Jascade does a little bit better, but again, right now the best we can do is slow down scar tissue formation. And so even though we don't know why some people go on to get fibrotic sarcoidosis, in stage 4 sarcoidosis, you have these what's known as fibroblast activation. And fibroblasts are what we call the effector cell of fibrosis, meaning they're like the primary cells responsible for this. Activated fibroblasts will deposit extracellular matrix as well as produce different profibrotic cytokines. And so generally the thought is that you have persistent granulomatous inflammation, right? It's not responding to our immunosuppressive therapies, and that leads to fibrotic remodeling. And as a result, you get the accumulation of these activated fibroblasts, and they all have, and then resulting in inflammatory and fibrotic mediators. And so again, in this little example, right, you take an area, if you look at people with fibrotic disease, you have granulomas, and then these granulomas, you have this persistent granuloma inflammation, then promotes the production of profibrotic cytokines, specifically TGF-beta, and that leads to fibroblast activation, leading to what's called myofibroblasts. They're going to, again, lead to the deposition of excessive collagen and other ECM proteins. A little bit about fibroblast heterogeneity. Again, the process that lead to fibroblast activation is really not clear, but overall they are activated by different inflammatory fibrotic stimuli, and activated fibroblasts, what we're finding now, is actually pretty functionally diverse. And efforts led by Dr. Kaminsky has really showed the genomic diversity of these fibroblasts, in that not all fibroblasts perform the same functions. Some are more inflammatory, some produce more inflammation, others produce more fibrosis. And then, and really the fibroblasts in IPF are the composition of fibroblasts in IPF are different than that. This is a study done in scleroderma ILD. And so these processes that mediate fibroblast activation remain unknown. And so we've attacked this from the angle of from innate immunity. And so innate immunity is our nonspecific fast-acting immune response. And then, which is different than our adaptive immune system, right? That's the one that's like when you get vaccinated, you get a response to specific pathogens. And so, given the fast-acting properties of innate immunity, they're involved in inflammation. And so what we've been focusing a lot on is TLR9. And so TLR9 is an endosomally located pathogen recognition receptor, and it recognizes repeated CpG DNA sequences. And these things are found in a lot of bacteria and fungi, and these are called PAMPs, pathogen-associated molecular patterns. But TLR9 can also recognize CpG sequences in DNA that's frequently released by stressed or dying cells. And so one of our frequent collaborators, Glenda Trujillo and her group, found that fibroblasts from patients with rapidly progressive phenotypes of IPF express more TLR9 than fibroblasts from those with slowly progressive IPF. And then, these fibroblasts from the rapidly progressive IPF group would more robustly express TLR9 when they got exposed to exogenous CpG DNA, exogenous CpG. And so this kind of led us to our question of what's the source of CpG in IPF. We know it's been proven that at this point that it's not infection. And so what we call this like an endogenous source, something that's coming from within. And so we hypothesize that this could be mitochondrial DNA. And so mitochondrial DNA is actually released by necrotic and dying cells in response to stress. And mitochondrial DNA, right, because of its bacterial origins, has a lot of these unmethylated CpGs, and it can actually activate TLR9. And so our first look and our first set of translational experiments that we conducted was to look at this mitochondrial DNA TLR9 axis in pulmonary fibrosis. And so, we had, again, having multiple cohorts in a disease that's rare, like IPF, is important. And what we found was that both in IPF patients at the University of Pittsburgh and also here at Yale had high levels of mitochondrial DNA in the blood. We were able to quantify the mitochondrial DNA, the TLR9 activity in the blood using what we call reporter cells. These cells will light up when they're exposed to a TLR9 ligand. And you can kind of quantify that. And we found that the mitochondrial DNA levels correlated directly with TLR9 activation in both cohorts. And then mitochondrial DNA looked like was predictive of mortality in both cohorts of patients with IPF. And because, again, IPF and scleroderma ILD behave differently, we explored the same mitochondrial DNA TLR9 interactions in scleroderma. And here we had access to patients from Yale and also from Boston University, and found that patients with scleroderma ILD highly expressed mitochondrial DNA in a manner that was, again, statistically correlated with TLR9 activation. And in scleroderma ILD, it tends to be a little bit less fibrotic than IPF. We found that mitochondrial DNA levels predict decline in FVC, right? And again, FVC is a critical marker of potential mortality in ILD. And so, putting this together, we looked at this mtDNA TLR9 axis in different experimental fibrosis models. And so we first looked at normal lung fibroblasts. Again, these are the main cells that are involved in fibrosis. And we induced fibrosis by giving them TGF-beta, profibrotic cytokine, as well as exogenous CpG, which we used as a surrogate for exogenous mitochondrial DNA, and found that it increases TLR9 expression and alpha SMA. And then we had a TLR9 inhibitor and found that it seemed to reduce the production of alpha SMA and, not surprisingly, TLR9. We also use what we call a precision cut lung slice model. These are very thin slices of lung tissue that are viable in cell culture. And again, we induce fibrosis using culturing them with TGF-beta and CpG. And this fibrotic process seemed to be halted with TLR9 inhibition. We also used a mouse model of fibrosis. Here, we gave these mice an adenovirus that contained an active form of TGF-beta to induce fibrosis. All the purple stuff, right? You can see that's excessive collagen. And then the amount of collagen seemed to get better with TLR9 inhibition, all showing that this mitochondrial DNA TLR9 activation appears to be indispensable for fibroblast activation and lung fibrosis. And so, just going back to the sarcoidosis space, taking all this, what we've learned about mtDNA TLR9 from IPF and SSc-ILD, we had sarcoidosis samples from the GRADS cohort, right? That was one of those multi-center studies. And we found that mitochondrial DNA is elevated in the blood of patients with sarcoidosis. Again, that was associated with TLR9. And we found that really patients with extrapulmonary disease had high levels of mitochondrial DNA, especially African-American patients with extrapulmonary disease seem to express high levels of mitochondrial DNA. And then I mentioned really quickly here, we looked at sarcoidosis-induced fatigue. This is a really debilitating symptom that is very difficult to treat. Sarcoidosis patients with fatigue will have this really severe fatigue despite no evidence of active disease, and all other causes of fatigue have been ruled out. And so we found that this is in the GRADS cohort. They use what's called the FAS, the Fatigue Assessment Score. It measures total fatigue, but also measures mental as well as physical fatigue. And we found that mitochondrial DNA statistically correlates with all levels of fatigue, and plasma TLR9 activation is also statistically correlated with all domains of fatigue. And so to put this together, we did what's called a statistical mediation analysis. And we found that here that that this mtDNA TLR9 axis partially mediates fatigue. And that makes sense because mitochondrial DNA, while it can activate TLR9, it also activates other innate immune receptors. So I think it's probably a combination thereof that kind of induces, at least mediates sarcoidosis-induced fatigue. And so we found that, concentrations of mitochondrial DNA in the circulation are associated, interact with TLR9, and are found in patients with sarcoidosis, particularly those with extrapulmonary disease and those who experience significant amounts of fatigue. And so the next step, so what are we doing here with everything that we've done, is that we're really trying to look at this mtDNA TLR9 fibroblast activation in fibrotic sarcoidosis. And so, I was able to use everything that we've learned up until now to kind of have this comprehensive translational platform where we're using human biospecimens, cell and lung culture. We have a lot of clinical data from our patients in clinic. We have different mouse models, and then really using different multi-omic methods to really discern how mtDNA mitochondrial DNA interacts with TLR9, and looking at different markers of fibroblast activation, and how we could ultimately leverage this to come up with new specific treatments for patients with sarcoidosis. And so with that, I'll be happy to take any questions.
Hello? Yeah. So Wonnie, what a really tour de force presentation of the last 13 years in the lab. And I really want to applaud you for picking yourself up after all that negative data that you showed. It's really remarkable just for people who maybe aren't publishing negative data and reporting it. It's unusual for somebody to actually stand up and show all their negative work. And for maybe more junior scientists, we can think about negative data not as a failure, but it's actually a success because we know what doesn't work, and it brings us now closer to what will actually help our patients. So thank you for role modeling that. Do people have questions for Wonnie? Well, while people might be formulating questions, I have a question. So the collagen neoepitopes study, that was an unexpected finding. And the mitochondrial DNA study was also unexpected because I recall the hypothesis was that you would recapitulate the situation in IPF or other forms of pulmonary fibrosis where a circulating fibrotic mediator is predictive of or reflective of fibrosis in the lung. What you found in sarcoidosis was that it was not reflective of a fibrotic situation, but instead reflective of multi-organ disease. Can you tell us what that means for similarities and differences between IPF and sarcoidosis?
Yeah, that's a really good question. What's that? Huh?
No, I asked him.
What? I think some of it is due to the fact that what people defined as fibrotic sarcoidosis differed across institution, and so harmonizing protocols when you have these multi-center studies is going to be important. I think there's probably some patients in the stage 2 group maybe that did have fibrosis, so I think we captured a little bit of that. And then also just the mechanism of disease is just so different. When you have persistent granulomatous inflammation that leads to fibrosis, I think the landscape it shows it's so different, and that's where I think some of the sequencing studies that we're doing now might kind of help enlighten us as to why we didn't see this, because the scleroderma ILD studies did show that it's reflective of what's going on in the lung. And so I think it's just shown that there's still a lot that we don't know about fibrosis, pulmonary fibrosis.
Thanks. We have another question.
Thank you. Thank you for the fascinating talk. I was curious, given the multi-organ nature of this disease, do you know if fibroblasts in the other organs also express the TLR9 and therefore may be responding in a similar way demonstrated in the lung?
Yeah, no, they like cardiac fibroblasts, and I think renal ones, renal fibroblasts, they do. And so maybe that's why too, right? That you have simultaneous fibrotic processes going on. And so maybe that's why, I don't know, maybe the mitochondrial DNA is all engaged in TLR9 or cGAS or some other innate immune receptor. And that's why we see such disparate outcomes. So yeah, maybe, yeah.
Other questions? Clemente.
Thank you. Hey, Wonnie, thank you so much. That was great. So is there some kind of therapeutic vision for these mitochondrial DNA or for trying to interrupt this TLR9 signaling? Do you see that going in the direction of a therapeutic agent? And also, are there sex-specific differences in those, in the free circulating, mitochondrial DNA or markers of inflammation? Thank you.
Yeah, so starting with the sex differences, and that's like a good point, right? Because it's all maternal inheritance, and so and when we looked at our cohorts, especially in the scleroderma group, we do see that the female patients have higher levels of mtDNA than their male counterparts, and so we do see some of them. We're really gonna tease that out. And then in terms of treatment, that ends up that's pretty tricky, right? Because we do have DNAs, right? You guys use that in the CF space. And so if you reduce all of that in the lung, maybe that might help be a therapeutic. We haven't really seen that, and the mitochondrial DNA is pretty sturdy. And so actually, what the DNase does for some of the DNAs is it will actually degrade all the other like random DNA molecule strands that are in there and just leave mtDNA. And so, and then when that happens, that seems to really hasten inflammation and fibrosis. So I think, definitely, I think targeting mtDNA in some way would be a pretty specific angle to take.
Naftali.
Can you reflect a little bit about I'm fascinated by the sort of the chronic fatigue. It's like the unspoken symptom and sarcoid, and actually for the patients who are not severe, probably the worst.
Right.
Yeah. How do we connect it? Do you think it's connected to chronic innate immune activation, smoldering inflammation? Is the mitochondrial DNA related to it beyond the phenomenon?
Yeah, no,
Are there ways to actually to intervene, right?
Right. Yeah, no, that's a really good question because, the more I got into that space, there's no correlation with disease activity. I think now there's a little bit more interest with like the chronic fatigue from COVID and all that stuff. I think people are taking more interest. The inflammatory marker, I think people have been searching for inflammation we had some proteomics data, none of it worked out either. And so maybe it's some combination of like maybe the metabolism, right? Some of the work that our PH group has shown that there's mitochondrial dysfunction in the post-COVID people. But like you can't really do anything about it right now. And so I think it's just going to be, there's going to be a publication coming out soon about looking at like both some inflammation, some of the like psychosocial stuff with like depression, anxiety that's getting exacerbated, maybe like a metabolic element too that you can address. People brought up GLP-1s and sarcoidosis, and maybe that, at least for some of the patient-related symptoms, it might help too. Yeah.
It's interesting from the big part because there's been such a poor response to anti-inflammatory therapy.
Yeah.
And when patients come in the clinic primarily for chronic fatigue, I find that about most of them leave frustrated with what we can do for them. Like the guidance, they have some experience with TNF with mixed results, but like a lot of sarcoidosis centers, like right now using modafinil and stimulants, and just giving up on the inflammation pathway, because up to 80% of patients in sarcoidosis surveys describe some component from fatigue, but for some of them, that's their main symptom.
And so it's, oh, yes, Dr. Homer.
You can finish, I'm sorry.
Was it relevant to what you were saying?
No.
Okay.
It has to do with the issue about inflammation, right? So the issue is that sepsis for years indicates that, it's pro-inflammatory, now we know it's actually a mixture of pro and inflammatory. So I guess the issue is, well, I went to a straight talk the other week on HIV, associated lung cancer, or even on effective antiretroviral therapy for normal CD4 count, their lung cancer don't do as well. And there's a model here at Yale where there's upregulation of checkpoint inhibitors. Basically, again, you have a thing where it's not just going forward, but it's kind of stuck, right? So there's a lot of upregulation of checkpoint inhibitors. I guess the question is, what do we know about the downregulation? Is sarcoid like that when they're both up and down and it's stuck in between? Do we know anything about checkpoint inhibitor pathways in sarcoid?
Yeah.
How does that sort of fit into that pathway? Because there's other chronic infections or post-inflammatory states where you see fatigue, right? So post-COVID chronic fatigue, post-BPD chronic fatigue, and that seems to be sort of a balance, an aberrant balance between the inability to resolve the process.
Yeah, so I don't know if anything has been done in the sarcoidosis space with like PD-1 inhibitors, but definitely in IPF. Oliver and Isis Fernandez has been working on that space a lot. So I think they've had some great success with that. I think the next treatment that we're going to see, potential treatment that we're going to see in sarcoidosis is mTOR inhibition with rapamycin. And so maybe some of that, like, where you need these cytokines, right? You can't completely knock them out. And so it is maintaining that balance of pro and anti-inflammatory cytokines. And so I think that maybe we're going to start to see some of that with rapamycin and some of this like mTOR stuff that's coming out soon too. So.
Thank you for that comment. I just wanted to finish then with something back to your comment. No, I'm just talking to him. So your comment had been about, thank you for pointing that out, Debbie. I wasn't meaning that JP and should talk to me, but so what your comment about sarcoidosis centers with fatigue are now prescribing stimulants, which would be potentially centrally acting. There's an emerging literature about TLR9 and mitochondrial DNA regulating neurogenesis in the central nervous system. And it's also now, people are now looking at mitochondrial DNA as a marker of neurodegenerative diseases such as Parkinson's, as well as some fascinating psychiatric stuff, where my favorite mitochondrial DNA article was the one about withdrawn adolescents with phone addiction have increase in circulating mitochondrial DNA that associates with antisocial tendencies. So it could be that the mitochondrial DNA that we're seeing in the circulation, or that Wonnie's seeing, has nothing to do with inflammation,
Right.
And it's that your brain is messed up. And so I think it's like such an exciting time to be in sarcoidosis, because we have all these cool hypotheses and we're talking about all these different treatments. And I mean, Rob, 25 years ago, did you ever think that somebody would be standing up to be all these trials in sarcoidosis? Yeah, it's amazing. Well, I think we've had a wonderful discussion today. I'd like to thank everyone, and thank you, Debbie, for organizing.
Thank you.